Herkese iyi akşamlar.
Good evening, ladies and gentlemen. I know you're all very tired and you're all very hungry, so I will try to make a very fast wrap up. I'm going to talk about sleep disorders. Sleep disorders are important in bipolar disorder, and there is a specific reason for that. I will try to talk about this too.
Bu bizim hastanemiz. Bu niye
This is our hospital. Why am I showing you this picture? This is Mood Disorder Center. It's a 2-floor center. Mood Disorder Center has some specialists working there. Iqbal and Meta are among with us. This is a 54-bed capacity. This is a building with 54 beds. Mevlana says, sleep, no matter where you go, no matter who you mingle with, those people will get lost, and those people will disappear. So do not drop by today, because this community is actually feeding us. Sleep disturbances are key characteristics of bipolar episodes, and most of the episodes of bipolar disorder are cross-sectionally associated with sleep rhythm abnormalities. Mania is strongly associated with decreased need for sleep. The reduced need for sleep is between 69 to 99%, and short sleep duration in mania is associated with severe symptoms. What do the polysomnographic changes in mania tell us? It reduced delta sleep, shortened total sleep time, increased time awake in bed, shortened periods of insomnia and hypertension. Insomnia can be seen. Insomnia and hypersomnia are both found in bipolar depression. Depressive episodes are like hypersomnia between 23 to 78% of patients. Insomnia is seen up to 100% of the patients. Prodrome of mania and depression are also seen. Both depression and mania have prodromal symptoms. In mania, it's the first prodromal symptom. In depression, it ranks sixth. Altered sleep often precedes deterioration of the existing episodes. Typically, shorter REM latency is observed. In depression, REM latency is typically shorter. There is increased REM density, and short-wave sleep abnormalities are seen. In rhythmic bipolar patients, sleep disturbance is observed. Sleep disturbance in the rhythmic period is a problem. There is increased sleep onset latency and increased sleep onset latency, increased sleep duration, more night-to-night variability. In the rhythmic periods, increased REM density and percentage of REM are observed. Again, acetylcholine agonist, erecholine, decreases REM latency, and this is a sensitive thing about the bipolar disease patients, bipolar patients. Sleep disturbance contributes to relapse. Short sleep duration is associated with more severe symptomatology. Both short and long sleep durations were associated with poorer function. This is step 1 trials, component about sleep. This is the total sleep duration, and this is the mania scores. When sleep is less, the symptoms of mania increase. Sleep deprivation in bipolar disorder is a very important problem. Actually, it's a method which has the effect of an antidepressant. In unipolar and bipolar depression, we see this method as a very helpful mechanism. In the older literature used to say that there is no difference in response to sleep between the unipolar and bipolar disorder, but the contrary is suggested recently. So sleep deprivation in the treatment of bipolar depression may be efficacious. This is what the APA's practice guideline on the treatment of bipolar disorder suggests. So decreased medial prefrontal cortical activity is also associated with sleep deprivation, and amygdala activity increase is also associated with sleep disorder. This is the Konya group. In bipolar disorder and sleep deprivation, and the response between those could be the result of an endotypical disorder. So in patients with bipolar disorder, this can be referred to as an endophenotype, according to the authors of this trial. Lithium affects the circadian system through its features, and it increases sleep disorders. Serotonin transporter gene 5-HTT-LPR functional polymorphism is more likely to respond to sleep deprivation, according to those trials. Sleep phase advance and timed light was ineffective for bipolar depression. Sleep deprivation is both a cause and a consequence of mania. It is unclear whether sleeplessness is a cause of mania or a prodromal symptom of mania. Which one is causing which, that we do not know clearly. Ömer and his friends have set forth this theory, which suggests that events with somatic effects like drugs, withdrawal, illness, etc., and events with psychic effects like separation, loss, role changes lead to insomnia, and events disrupting sleep schedules like newborns, travels, shift work, and social activities lead into sleep deprivation. This causes sleep reduction and causes mania, and then they are involved in a vicious cycle. The primary sleep disorders like obstructive sleep apnea cause sleep reduction, and they trigger mania, or the manic symptoms might increase. Sleep deprivation is a potential trigger for mania. As we said before, sleep duration may also be a predictor for mania. If this is the case, then disturbed sleep is a marker of impending or developed mania. Greater total sleep time on the first night of hospitalization was associated with faster response, according to a trial carried out on hospitalized patients. Significant correlation between duration of sleep and ratings of cooperation and irritability on the nurse's observation scale for inpatient evaluation. Cooperation increases to the same extent. In mania, sleep, is this a treatment objective? Let's talk about this now. The clinicians have long used therapeutic agents that target disordered sleep in manic patients. The sedative drugs were used in the treatment of psychiatric diseases like bromides, chloroform, alcohol, and opium. And in the 19th century, before the advent of pharmacological management, again, they were used for the treatment of such patients. Prolonged bed rest and the rest cure were initially used as methods.
Yine şu anda da sedasyon bizim kullandığımız
Sedation is one of the methods that we're using, and some of the instruments that we're using today cause sedation. However, sedation, is it suppressing the manic symptoms or is it correcting the underlying pathology? This is not very clear yet. In a trial conducted, patients were enforced to darkness for 14 hours. And in addition to the drug regimen, this practice has shown that there was significant decrease in YMRS scores when treatment occurred within 2 weeks of onset of the manic episodes. The improvements seen with bed rest and enforced darkness may occur through circadian episodes. The sedating medications most frequently used today in the acute phase of mania have been benzodiazepines and antipsychotics. These two are the drugs that we're using the most. The antipsychotics, the majority of them also cause sleep. These are common features of those drugs. Melatonin, it does not cause sleep, but when the circadian cycle is impaired, it might correct the sleep disorder. And in this trial, Bersani and Garavini used melatonin as a hypnotic, and it was shown to have a positive effect on sleep disorder. Before the manic episode, sleep disturbance was by far the most commonly reported prodromal symptom prior to a manic episode. So teaching patients to recognize early symptoms of a manic relapse is an important issue. Impaired sleep may represent vulnerability to relapse. Both short and long sleep durations are associated with poorer function and quality of life. So, in the atomic period, in the follow-up of the patient, sleep monitoring requires special attention. How are we going to evaluate the sleep pattern of the patient? First, we have to listen to patient history, and we should try to see whether there are other factors which cause this. Primary sleep disorders should be sought. Obstructive sleep apnea and restless leg syndrome should be questioned in the first place. This is important because obstructive apnea and restless leg syndrome disturb the night sleep and might trigger relapse as a result of this. Obstructive sleep apnea and restless leg are widespread among the society. One is 2 to 4%, the other one is 2 to 7% respectively. I think in psychiatric disorders the rates are higher. Bipolar disorders had 60% of them had those problems according to one trial. The trial's name, the trial is a trial conducted by Hattori and his colleagues. Polysomnography can be required in certain cases. What are features of OSA-HS? Excessive daytime sleepiness, impaired concentration, snoring, unrefreshing sleep, choking episodes during sleep, witnessed apneas, decreased libido. Let's talk about the diagnostic criteria for OSA-HS. There has to be apnea and sleepiness during day. If there is no excessive daytime sleepiness, then other criteria mentioned here should be sought. 2 out of 5 criteria should be present in order for the diagnosis to be made. Obesity, male gender, family history, alcohol, smoking, and craniofacial abnormalities and hypothyroidism are the risk factors. Obesity is important to us because obesity is a major risk factor for the disorder, and it may be critically important in bipolar populations. Obese patients experienced a greater number of lifetime mood episodes and tended to be more severe and more difficult. Obesity in bipolar patients may be iatrogenic, so that also is something to take into account. We see almost 50 patients per day. So how are we going to monitor this disorder? If the color size is higher than 43 in men, higher than 38 in female, and if the BMI is above 30, then we can talk about this diagnosis. Restless leg syndrome is another important primary problem. Restless leg syndrome can be screened for by inquiring whether the patient experiences an urge to move his or her leg when at rest. These unwanted movements can disturb the sleep and will have a negative effect on the course of the disease. Sleep disorders are very often, and between the episodes and in the atypical periods, the incidence might be quite high. There might be problems in sleeping. Multiple or prolonged awakenings from sleep and inadequate sleep quality are also problems. Psychotherapeutic and psychotherapeutic problems are being used, like hygiene treatments, and there are exercise-related recommendations, light, noise, temperature-related recommendations. There should be no light, no noise. Temperature should be ideal, and nothing should be eaten after a certain hour. Tea and coffee consumption should be reduced, or you should go to bed only when you're sleepy. You should get out of bed when unable to sleep. And it is important to wake up at the same hour every morning. No naps during the day. If there is anxiety, it should be eliminated. If cognitive therapy is necessary, cognitive techniques should be used. In bipolar, interpersonal and social rhythm therapy are useful. They have positive results in the long run. Stressful life events affect the course of the illness, partly by disrupting daily routines and social rhythms. Therefore, the cycle is disrupted, and as a result of this, bipolar disorder's course is also affected by this. The purpose of the therapy is to ensure that the disturbance in daily rhythm and the problems in interpersonal relations are eliminated, and the course of the disease is affected positively. Bipolar disorder patients are more vulnerable to the effects of social rhythm disturbances, and impact of interpersonal events on social and circadian rhythms should be discussed with the patients. In pharmacotherapy, the drugs we can use are benzodiazepines, benzodiazepine receptor agonists, sedating antidepressants, anticonvulsants, sedating antipsychotics, and melatonin receptor agonists. Benzodiazepines are used the most. However, misuse, tolerance, withdrawal, and sedation are side effects, so these are not agents that we can use at all times. Benzodiazepine receptor agonists have short-acting effects, so their adverse effects are less. They are more specific to GABA receptors, and they have shorter intermediate half-lives. Zopleon will be available in Turkey soon. If so, hopefully we shall start using it. However, these drugs have a potential for addiction. Most commonly prescribed, the antidepressants are most commonly prescribed to treat chronic insomnia and sedating antidepressants are also used for the same purpose. Anticonvulsants, gabapentin, topiramate, and tiagabine are also sometimes used for the same purpose. Antipsychotics, it's about to finish. Antipsychotics are also agents that we use a lot. However, metabolic abnormalities should be taken into account. So is EPS, and sleep-related movement disorders can increase. Quetiapine is an agent that we can use a lot. It increases sleep duration and sleep quality when used in small amounts. Melatonin is another option. The melatonin agonists are also efficacious under those conditions. And this is my team and team members, and I will